It's my pleasure to be with my dear colleagues and professors here in the IAVA. It's the annual festival of the recent in medicine, in dyslipidemia management, in heart failure management, in all cardiology aspects. And I would like to congratulate Professor Ashraf Reda, the president of the IAVA, and the board for the very successful meeting every year. I would like to welcome my dearest friends, Dr. Shah and Dr. Sulaiman. And I would like to present my dearest Professor Ihab Attia, Professor of Cardiology at Ain Shams University. And he will give us a commercial lecture about plaque regression and stabilization, the emerging role of PCSK9 inhibitors. And we all know that now it's the era of how to regress atherosclerosis, how to measure the plaque regression, what are the studies that show plaque regression after ACS or even in the non-culprit vessels can reduce the total cardiovascular risk, and how to image these plaques, what are the measurements, what is the evidence of this on the current cardiovascular events. All of this will be addressed by Professor Ihab Attia, and we know that he will show us that in a very elegant way as usual. Please, Dr. Ihab, go ahead.
Thank you very much. Really excellent introduction, Professor Amr. First, Bardo, I would like to always congratulate Professor Ashraf Reda. Excellent meeting and the IAVA group. I hope the sound is clear. Today I'm just going to discuss the role of PCSK9 inhibitors and mainly alirocumab regarding plaque regression and stabilization, because we already know that it's been effective regarding cardiovascular outcomes. We have all the data, the wonderful data from the Odyssey outcome trial. And I'll take just a quick background. We all know the mechanism of plaque formation. I don't need to go through it, but however, this is how the plaque forms, and this is what we get.
صوت ورا يا جماعة، صوت ورا لو سمحتوا. نركز مع دكتور إيهاب لو سمحت.
And this is what we find at the end of the day. We get an atheromatous artery with an atheroma core, a fibrous cap, and as well, we get some macrophage infiltration with spotty calcifications, as we see on the diagram on the right side. We need to study this plaque. So we have tools to study this plaque, and it depends what we want to see. If we want to see the lumen, as we are used to by coronary angiography, or even by IVUS or OCT, that's okay. But when we are looking at plaque burden, we are looking mainly by IVUS, grayscale IVUS. When we're looking at the lipids and the lipid core burden, which is an important target for us, we're looking by the always near-infrared spectroscopy. So the near-infrared spectroscopy will get us the lipid core burden. When we look about the stability of the plaque and the fibrous cap, and we're looking at the thickness, we know the thicker the fibrous cap, the more stable the plaque. So we're looking by OCT, optical coherence tomography, as well as macrophages. So we use the tools that will show us what we need to get. Most of the studies that studied plaque regression with the statin trials and even some of the other PCSK9 inhibitors used IVUS mainly. However, when we're talking about alirocumab, and we already know, like we heard from Professor Moheb, who showed us the major advantages regarding reduction of cardiovascular outcomes from the Odyssey outcomes trial. We already know this after ACS. The question always remains whether these patients who just recovered from an ACS are always subjected to an increased risk of atherothrombotic events, mainly in the early period after the ACS, because they usually harbor high-risk plaques in non-infarct-related arteries. So when we treat the infarct-related artery, the culprit, by primary PCI, and we usually observe during our angiography that there are other non-infarct related plaques available in other arteries. We don't really know their significance and what we can do to help our patient. So this was the background for the Pacman AMI randomized clinical trial that was presented at the ACC this year and was published in the JAMA April 2022. And briefly going through it, like I said, we have coronary plaques that are responsible for the acute myocardial infarction, and these contain large plaque burden with a lipid-rich pool that is covered by a thin fibrous cap. So we have to look at these characteristics by intracoronary imaging in order to pick these high-risk plaque characteristics and deal with it. However, till that time, the effect of alirocumab on these high-risk plaque characteristics when it's given early after ACS was unknown. We didn't know whether if we give alirocumab to these patients quite early after ACS, is it going to have an impact on the characteristics of a high-risk plaque. So the aim of the study was to determine the effect of early administration of alirocumab on top of high-intensity statin therapy. I always emphasize that it's on top of high-intensity statin therapy on coronary plaque characteristics. And what is really unique to this study is it looked not only at one vessel like most other studies, but it looked at two vessels with multimodality intracoronary imaging. So they looked by IVUS, by near-infrared spectroscopy, by OCT as well in these patients who had acute myocardial infarction, and they followed them up to 52 weeks. So briefly, these patients had non-STEMI and STEMI almost in an equal number of patients, and they underwent coronary angiography, and they had the successful primary PCI to the culprit infarct vessel, and those that had two non-infarct related arteries with non-obstructive lesions with a coronary, let's say a plaque causing a stenosis with a diameter that's more than 20% but below 50% were included in the study. Eventually, the study managed to enroll 300 patients. They looked at the LDL before entering into the study. If the patient was receiving statins, then if the LDL was still above 70, he was included. Those that were statin naive or did not receive statin at least the 4 weeks before the study, they were included if the LDL was more than 125 milligram per deciliter. And they were studied by, like I said, the IVUS, the near-infrared spectroscopy, and OCT. They were randomized into one-to-one, two groups, a group that stayed on rosuvastatin 20 milligrams without any change in the dose all through the duration of the study, and the active group, which included rosuvastatin 20 plus alirocumab 150 milligrams subcutaneously every 2 weeks. And at 52 weeks, again, they were studied by the same thing. We looked by IVUS, by infrared spectroscopy, as well as OCT. And these patients, of course, were followed with regular clinic visits as well as phone visits during the period of follow-up. However, let's look at the primary endpoint of the study. The primary endpoint of the study was the change in percent atheroma volume by IVUS. We already know, we've seen from a lot of regression studies how to calculate the percent atheroma volume, measuring the cross-sectional area between the external elastic membrane and the lumen cross-sectional area, divided by that area inside the external elastic membrane multiplied by 100. So the primary endpoint was the change in percent atheroma volume. That was the main primary endpoint, but there were secondary endpoints that were powered as well. And one of them was looking at the change in maximal lipid core burden index by infrared spectroscopy. So they will look at the 4 millimeter segment that had the highest lipid probability, and this is what they looked at by the near-infrared spectroscopy catheter, and the change was calculated. And they also looked at the change in minimal fibrous cap thickness by OCT. So the OCT will look at the area that had lipid-rich plaques, and they would measure the minimal fibrous cap thickness and then follow it up at the end of the study. So this has all these modalities within the same study, and this is the strength of that trial. Of course, as usual, we are interested in the reduction in LDL in such a trial, and it was quite impressive. Remember, they were receiving rosuvastatin 20 plus alirocumab, and as you can see, the arm with alirocumab had almost an 85% reduction in LDL, reaching a mean level of 23 milligram per deciliter, compared to placebo. Placebo is rosuvastatin 20. So there's quite a marked difference between them, and that's of interest. But the primary endpoint, which is the change in percent atheroma volume, was impressive also. The alirocumab arm, we had a minus 2.1 compared to rosuva. Rosuva also caused some reduction in percent atheroma volume. It was 0.9, but the difference between both arms was statistically significant, and that difference was 1.2%. So we had a 1.2% difference between them in 1 year. That's the primary endpoint. The powered secondary endpoints, again, like I said, in change in maximal lipid core burden index in the 4 millimeter having the highest lipid probability. It also showed quite significant difference between both arms, with the alirocumab arm showing a marked difference compared to rosuvastatin with statistical significance. And finally, when we look at the minimum fibrous cap thickness by OCT, and like I said, the thicker the cap, the more stable that plaque is. And with alirocumab, the minimum fibrous cap thickness was higher, larger than that by rosuvastatin, again reaching statistical significance. Rosuvastatin also increased the fibrous cap thickness, but not as much as with alirocumab. So this was an added benefit there. And you can see here very elegantly shown the relationship between the LDL levels and the endpoints, the primary endpoints and the secondary endpoints. You can look and see with the LDL, with the solid line, the LDL going down, you can find that there is the change in percent atheroma volume being reduced, the maximum lipid core burden index also going down, and on the far right, you can see the fibrous cap thickness going up, meaning that it's getting thicker, so the plaque is getting more stable. This is a case example from the study, and you can see at baseline on top compared to 52 weeks. And when we look at the percent atheroma volume, you can see that it was, in this example, it was reduced between 62%, it went down to 50%. And you can appreciate that this is the exact same segment, because if you look at the calcification line, the linear line of calcification between 3 o'clock and 5 o'clock, you'll find it the same between both images. And also that same area, when we look at the maximum lipid core burden index, we find it dramatically, also visually, it went quite significantly down, but dramatically down as well. When the fibrous cap, you can see that the minimal fibrous cap increased from 56 micrometers to 158 micrometers in that example. So that's an example of one of these cases. So they concluded that compared with placebo, and placebo here is rosuvastatin 20, it's a high-intensity statin, alirocumab initiated in the setting. Remember, these patients were less than 24 hours after their index acute myocardial infarction. So alirocumab was started less than 24 hours after that of acute myocardial infarction, on top of high-intensity statin therapy, resulted in greater decrease in percent atheroma volume, larger reduction in lipid burden, and a higher increase in minimal fibrous cap thickness, 52 weeks of treatment. So this indicated that you can expect incremental coronary plaque regression, you can expect a lipid core reduction and plaque stabilization with alirocumab on top of high-intensity statin, and this provides us with a mechanistic rationale in favor of early initiation of very intensive LDL lowering in acute myocardial infarction patients, because we did not have that information we now know that not only we're reducing the LDL and outcomes later on, but also we are affecting the plaque in non-infarct related arteries. Remember, these are non-infarct related arteries waiting to do a catastrophe. So we are stabilizing these plaques by interfering quite early with high-intensity lipid-lowering therapy. I'm not saying high-intensity statin, it's high-intensity lipid-lowering therapy. So does it have any significance? Because I know a lot of colleagues will say, so what? We have a regression of 1% or 2%. In this example, it was, the difference was quite significant, but even a 1% reduction in the plaque, when we see from this elegant study by Stephen Nicholas from 2010, published in the JACC, and when they divided the subjects into quartiles, you see those that had the highest plaque volume compared to the lowest, the least plaque volume, even though the difference is just 0.55%, almost 0.5%, but this showed a difference in cardiovascular events. So he demonstrated that even a minimal reduction in that plaque resulted in a reduction in cardiovascular events. So when I say a 2% difference, it's quite meaningful. So why should we look out for lipid-rich plaques? We already know from multiple studies, you know, the CLIMA study, the combined using OCT, the lipid-rich particles study, the Prospect 2 study, they also looked by infrared spectroscopy about the lipid core. All these studies showed that when you have this lipid-rich plaques, it carries a 5 to 7 times increased risk at the patient level or at the lesion level of the lesion being high risk, vulnerable, and rupturing, causing an event. So we have to look at these lipid-rich plaques and interfere if we want to really protect these patients. I'm going to finalize with some sub-study from the Pacman study that again was presented at the ESC Congress in Barcelona just a few months ago, and namely talking about the Architect study, looking at alirocumab reducing total coronary plaque burden in patients with familial hypercholesterolemia. These patients are quite common. I'm sure that most of us, at least every week, they see more than one patient with heterozygous familial hypercholesterolemia. They're quite common. We see them a lot. And in this study, these patients had no previous clinical atherosclerotic disease. So they did not have any prior atherosclerotic disease. And as such, this is the first study to see PCSK9 inhibition effect on the coronary plaque burden in such familial hypercholesterolemia patients. So they studied these group of patients with alirocumab, again once every 2 weeks as we usually do, and to see if it could reverse or stop the coronary atherosclerosis progression by multi-slice CT. This was a Spanish study, and these patients were part of the Spanish registry. And it was an open label, multi-center, low intervention, because it was just adding alirocumab to these patients who already taking statins at the maximally tolerated dose together with ezetimibe if the physician found that necessary. So on top of these, they took alirocumab, and it was studied for 18 months in these patients to see the effect on coronary atherosclerotic plaques. And like I said, they had no prior clinical atherosclerotic cardiovascular disease. They were asymptomatic. They had stable treatment with maximal tolerated dose of statin and ezetimibe. Their LDL had to be, despite the statin and ezetimibe, still above 100 milligram per deciliter. And they had to have, by multi-slice, at least a 30% or more coronary plaque burden by multi-slice, and as such, they were included in that study. Looking again at the LDL, quite impressive reduction of a mean LDL of 139 to 45 at 18 months, and you can see the stability of the reduction of LDL from the 3rd month onwards till the 18th month, quite significant. And when we look also at the primary endpoint, which is the change in coronary plaque burden, you find compared to baseline, they see the bar graphs on the right, the baseline, and after 18 months, quite impressive, again, reduction there. Not only that, but the characteristics of the coronary atherosclerosis, they also noticed an increase in the proportion of calcified and mainly fibrous plaque. You know that when they get more fibrous or calcified, it should be a little more stable than a soft lipid-rich plaque. And this was accompanied by a decrease in the percentage of fibrofatty and necrotic plaque in these patients. Again, they looked at the atherosclerotic plaque volume, which was significantly reduced between baseline and 18 months later. The number of or percentage of patients who regressed in this study was almost 90% that showed the regression, while like 10 to 12% did not show plaque regression. So the majority, the vast majority, showed plaque regression, and this demonstrated that treatment with alirocumab, in addition to high-intensity statin therapy, resulted in significant regression of coronary plaque burden and plaque stabilization as well. And this was shown by multi-slice CT over 78 weeks in both men and women with familial hypercholesterolemia without any clinical atherosclerotic cardiovascular disease. I think we missed a study. This I'm getting from the guidelines. You all know these slides. You've seen them before. I'm just reminding you that now the guidelines, especially the Europeans, are promoting more urgent need for intensive lipid lowering in patients that already have ACS, maybe early after the event, even during hospitalization if possible, in those patients that already have come taking high intensity or maximally tolerated statins and ezetimibe, and they are still not at LD goal, and they came with an ACS, then PCSK9 inhibitor could be given early after the event, even during hospitalization, and we now have data that shows that this is beneficial even for non-infarct-related arteries as well. Other patients who already came without taking any lipid lowering, if they take a high-intensity statin and ezetimibe after ACS and they don't reach their goal, after 4 to 6 weeks, we can add a PCSK9 inhibitor without waiting any further. So these are the new recommendations. And I think Professor Mohib showed this slide. You already saw it, and you know it. Especially interesting is the extremely high-risk patient, that patient that had history of other vascular events, peripheral arterial disease, polyvascular disease, or multi-vessel coronary disease, and familial hypercholesterolemia, don't forget. These are the kind of patients where a recommendation would be to have statin, ezetimibe, and PCSK9 targeted therapy, whichever targeted therapy you will choose for these extremely high-risk patients. So I just wanted to show another slide. I can't really see it here. It must have gone. I wanted to show that before I take my conclusion slide, that when we give intensive lipid lowering, we expect reduction of LDL early, and then we start expecting reduction of events taking a little bit longer, maybe weeks to months, but when we go to years, it should translate into maybe a reduction in mortality, not only in events. So from these studies, the Pacman, AMI, and Architect studies, they show mechanistic rationale for early initiation, like I said, of intensive, of very intensive LDL lowering. We saw from the guidelines that when we combine all these together, we can get up to 85% reduction, and it was shown in the Pacman AMI study, even though in the Pacman, ezetimibe was not used at the time except in maybe 1% of cases. But if you use ezetimibe, you get definitely an 85% reduction in the LDL. So this is quite beneficial in very high-risk patients and in high-risk patients. The sub-study of Pacman showed the insights on atherosclerotic disease progression, and how we can really benefit our patients, because the greater the risk, the larger will be the outcome benefit, and the higher you find the plaque burden, the larger the disease regression, and of course, as we all know, the lower the LDL, the better. And the European guidelines, again, advocate for more intensive combination of lipid therapies in high-risk patients, including familial hypercholesterolemia. So to terminate, I mean, now we have like we have in other diseases. Remember when we have diseases like heart failure and we find drugs that work, and we always want to know the mechanism. Why did this drug work? For example, with sacubitril valsartan, and then we found out there is remodeling benefits and so on. So same thing here. So with alirocumab, yes, we reduced outcomes, but we are now having more mechanistic insights into reduction of risky atherosclerotic plaques as well as regression. Thank you for your attention.
Thank you, Dr. Ihab. I will take from your last sentence that we found other drugs that is not working even on the cholesterol metabolism that leads to similar results, like colchicine. Colchicine can result in major reduction as add-on therapy to future events. So, do you think that plaque volume regression is a surrogate marker of prevention of future events? I know that 1% reduction adds at least 20% of the odds major events in the meta-analysis. But as regards the future events, is plaque regression, is it a clear question? Plaque regression has a direct evidence to reduction in the future events?
Actually, I'm much more impressed with this study with the maximal lipid core burden index. I think this is more telling because this changes the characteristics of the regression is well and good, even if we get, like we said, we showed that when you get a regression of 0.55%, you get reduced events, which answers your question. But I'm saying what's really interests me more is that if we get the lipid core burden index reduced quite impressively, we get a thicker fibrous cap, then this will at least give us the satisfaction that we are protecting our patient rather than leaving a risky plaque that can erupt or rupture at any time. So the answer is yes.
Just a small add-on. Do you think that the multi-slice CT is effective in this way as regard the architect? The CCT is useful to evaluate the plaques, plaque components and regression, and can be used as a future tool to assess the vulnerable plaques?
Not as good as, of course, when you go invasively, but there are the new add-ons, the software that's added to the, not the regular multi-slice CT that we see in our daily practice. There is addition that shows whether this plaque is really, it's a hot plaque or an active plaque or it's a stable plaque, but it will never show us the detailed information we get with a near-infrared spectroscopy or the exact measurement of a fibrous gap. Excuse me? Yes, but they have, not looking just at what we get from the data so far that we have percentage, it's usually not that accurate even. But there are software that's improving this.
أولاً thank you so much, and كالعادة I learned a lot. ببقى فاكر إن أنا عارف كتير وبعدين أكتشف إن أنا عارف قليل. I always learn from your presentations. Thank you very much. I have أولاً comment على البلاك volume. My question حاجة تانية. Plaque volume has been shown for multiple studies previously, specifically by Stephen Nissen, اللي هو كان using IVUS. He showed the correlation إنه أقوى correlation بالlong-term events هي البلاك volume. إن أنت كل ما بتقلل plaque volume long-term events بتقل. Multiple IVUS studies by Stephen Nissen specifically. النقطة الثانية اللي أنا كنت عايز أسأل عليها regarding البلاك thickness، يمكن أنت هتوريتها وأنا ما خدتش بالي. الكاب thickness انه you showed انه الفولو اب كان 52 اسبوع في الباكمان وفي السب ستادي كان 18 شهر. الامبروفمنت thickening of the fiber of the plaque, الvulnerable plaque كان بيحصل عند ال 52 weeks ولا كان بيحصل من قبل كده؟ The second part of my question, هل كان في أي علاقة بين ال extent of plaque thickness وال extent of decrease في ال LDL ولا ما وروش هم الداتا دي؟
لا there isn't الداتا دايركت ما بينها ما بين ال LDL وال change in plaque thickness. لأن هو ال LDL it went dramatically in all of them.
من 136 ل
Yes.
34.
ردا على البارت 1 ان هو بالسب ستدي كانت المالتي سلايس سي تي ف they did not measure الفايبرس كاب ثيكنس، انما التانيين بالاو سي تي في الباكمان نفسها امي they studied 52 weeks فورت dramatic change يعني almost الثيكنس الكيس اللي انا I showed an example almost 3 times thickness بتاع البيز لاين ف it was quite significant for 52 weeks.
Okay, thank you.
Thank you.
To rehab,
أيفن.
there is a correlation between the calcification of the plaque and the alirocumab or no?
يعني هو this is what they showed هنا في الستادي زي ما شفنا ان احنا even الكالسيفيكيشن والفايبرس دي في السب ستادي بتاعتها انها it increased using الاليركوماب ف there is ودي بتدي ان في stability و more ان البلاك دي is more stable less vulnerable to erosion or rupture. The answer is yes. زي سالم هو الستاتين ورت يعني احنا المسج اللي ناخده من الستاديز ان الستاتين بالذات في اول ستادي الباكمان امي ورت ان في ريجريشن بسيط ورت ان الفايبرس كاب في انكريس بسيط وورت في الليبيد كور بيردن اندكس في برضه ريدكشن بس مش بقوه الاليروكيوماب اون توب. يعني هي الستاتينز بيعملوا الحاجات دي بس ما بيعملوهاش بالدرجه نفسها اللي هي عملها الاليروكيوماب اون توب. فهي دي المعلومه اللي احنا دايما بنقول طب اوكي نزلنا ال LDL بس المريض استفاد ايه اكتر. فدي بتوري لاول مره ان as early as less than 24 hours after acute myocardial infarction في استفاده في البلاكس اللي هي non-infarct related.
Okay, one comment. Okay.
Last comment.
Thank you very much for your elegant lecture as usual يعني. أنا ليا بس تعليق على الباكمان MRI إنه البلاسيبو وصل ل 70 المفروض إنه التارجت بتاعنا 55 واستخدموا ريسوفا 20
الاستادي معموله 2017
بس
البدايه بتاعتها.
يعني هو معموله على التارجتس القديمه مش عارفين طب لو التارجتس جديده زائد انه رسوفا 20 ما انت ممكن تدي 40 عشان توصلهم للتارجت ده او تزود مع ازيتامايب. يعني قصدي انه البلاسيبو بالليفلز اللي احنا بنشوفها دلوقتي او التارجتس بتاعتنا على حسب الجايد لاينز بلاسيبو did not reach الجايد لاينز where they are candidates of other addition of for the treatment or to have PCSK9.
Excellent question. انا خليني اسالك انا سؤال. حضرتك تعتقد لما هزود لرسوفا 40 هيحصل ايه من 20 ل 40؟
رسوفا يعني انا هقول لك من personal experience انا شفت ناس على ماكسيمم ستاتين ولدتهم رسوفا 40 بلس ازيتامايب.
Dear doctor, your time is up.
لان at the time الازيتامايب ما كانش لسه في واخد القوه. لو كلمنا رسوفا لوحده زودناه 40 هيعمل لي ايه في ال LDL؟
زود 6%.
يعني هينزل لي LDL قد ايه on top of the 20؟ how percent قد ايه؟ عمره ما هيدي اللي هيديه الاليروكيوماب.
Okay, thanks Dr. Ihab for this elegant presentation. Okay.
Thank you.
Next session, please.